We identified risk factors for allergic cross-reactivity among penicillin, cephalosporins, carbapenems, and monobactams. Now, let's distinguish between common types of superficial and necrotizing soft tissue infections, including causative pathogens. Here are some terminology of skin lesions that are helpful when discussing skin and soft tissue infections. So a macule, and you can see a picture of it here, is a flat circumscribed area that is a change in the color of the skin. Now, a papule is a small raised solid pimple or swelling, often forming part of a rash on the skin and typically inflamed but not producing pus. A vesicle is a small fluid-filled sac, and a pustule is a small blister or pimple on the skin containing pus. So you can visibly see the pus here. And bulla, which some would call it a blister, is a bubble-like cavity filled with air or fluid. And of course, crust is the dried serum, blood, or purulent exudate, which is typically the final phase of skin lesions. It's important to consider the anatomy of skin and soft tissue structure when discussing skin and soft tissue infection. So you can essentially think of the layers here. So at the very top, we have skin. Under the skin is the subcutaneous tissue, and then under that there is muscle. Now within skin, we can think of epidermis and dermis. Epi means above, so epidermis is above dermis. And then in the subcutaneous tissue, we have superficial fascia or fascia. And then under it, we have subcutaneous fat, nerves, and arteries and veins, and followed with, deep fascia, and of course, muscle underneath. Now, depending on what layer, we will talk about specific infections based on how deep we go into the skin structure. Now, impetigo or impetigo, characterized by erythematous papules, which then develop into vesicles and pustules, will eventually form a honey-colored crust. And this is essentially in the epidermis layer. Ectyma or ecthyma essentially is similar to impetigo, but it extends into the dermis skin layer. So it's still in the skin, but it's a bit, deeper. Furuncle or a boil is an infection of the hair follicle that extends through the dermis and into the subcutaneous tissue. Carbuncle is infection involving several adjacent follicles that are deeper than furuncle, which typically drain pus from several orifices. An abscess is a collection of pus within the dermis and deeper layers of the skin. Cellulitis is an acute spreading inflammation of the epidermis, dermis, and possibly the superficial fascia. It's characterized by erythema and edema of the skin that is not elevated and has poorly defined margins. Erysipelas is similar cellulitis but with a raised border and clearly demarcated margin. These infections are considered superficial in the sense that they are not necrotizing. When it comes to necrotizing soft tissue infection, essentially we get deep into the skin tissue. Cellulitis is kind of unique because it can be superficial, but it can also cross into deeper tissue. So there, a small portion of cellulitis can be necrotizing. So it will be the necrosis of dermal and subcutaneous tissue. However, once we go into the fascia, we essentially label it as necrotizing fasciitis. And when the muscle is involved underneath, it's essentially a myonecrosis. Now, there are different parts of the body that can have different types of necrotizing soft tissue infections. So you can see on this picture. And there are different ways to classify this. So one method is to have type 1, 2, 3, and 4. And there are some disagreements over this typing. But essentially, as of 2023, a proposed classification is that type 1 is essentially polymicrobial infection, when it comes to necrotizing. Type 2 necrotizing infections are monomicrobial, so typically group A, strep or Staphylococcus aureus. Type 3 is reserved specifically for Vibrio vulnificus or Aeromonas hydrophila, and type 4 for fungal infections. All necrotizing infections are considered a medical emergency, so they need to essentially be evaluated by surgeons urgently. And one thing that's important to understand about pathophysiology of necrotizing soft tissue infections is the presence of toxins. So the two or three common organisms that cause necrotizing, group A, Streptococcus. So this is Streptococcus pyogenes, is known for producing exotoxins. And, when these toxins essentially enter the tissue, they can cause severe necrosis. Staphylococcus aureus, some strains of Staphylococcus aureus can also exhibit exotoxins, as well as some Clostridia species. So Clostridium perfringens, for example, produces exotoxins. And what's to understand is that exotoxins have a role in necrotizing skin infections. And that's something that we'll talk about when we talk about selecting appropriate treatment. So we will need something with antitoxin effect. Now, because Staphylococcus aureus is often found on the skin, so it has a huge role in skin and soft tissue infections. So it's important to consider, in particular, methicillin-resistant Staph aureus or MRSA. Now, the good news is that the incidence of MRSA infections, in general, all infections, not just skin and soft tissue infections, in the hospital are actually declining year after year. So this was the 2019 CDC data that showed up to 2017 that, it's dropping. However, it's important to notice that when you compare to other infections, that MRSA is actually pretty common. So, estimated cases in hospitals patients in 2017 was over 300,000 cases, whereas C. diff was about 223,000. ESBL is 197. So you compare to other, bad organisms, MRSA is pretty much, more common. And when you consider estimated death, although more people have died from C. diff in 2017, still, over 10,000 people have died as a result of MRSA infections. And that's all infections in general, not necessarily skin and soft tissue infections, just to emphasize the importance of MRSA when it comes to infections. Now, with skin and soft tissue infections in particular, we can kind of consider severity on a spectrum. So impetigo and ecthyma, very superficial. So impetigo is in the epidermis and thymus into the dermis, right? So these are pretty mild in general, and they may be less severe or even similar to purulent SSTI. So purulent meaning that it doesn't matter what type of SSTI, it's essentially producing pus. And most severe would be necrotizing SSTIs that could lead to essentially toxic shock syndrome and mortality. Now, impetigo is broken into bullous and non-bullous impetigo. Essentially, most common cause of bullous impetigo is toxin-producing Staphylococcus aureus, and most of these are actually MSSA, so we're not really concerned about MRSA specifically. Non-bullous could be due to beta hemolytic streptococci. So that's, essentially group A strep, Streptococcus pyogenes, or Staph aureus, or both. And that's still MSSA. So it's not necessary to cover MRSA for these superficial infections. When it comes to, I should mention this is the same for ecthyma as well. For purulent SSTIs, and some examples of purulent includes furuncle, carbuncle, and abscess. This is primarily Staphylococcus aureus, and that could be MRSA, so MSSA or MRSA. With cellulitis or erysipelas, it is mostly beta hemolytic strep. and rarely it can be group B or Staphylococcus aureus. And the most severe necrotizing fasciitis, that's typically due to beta hemolytic strep, and that's commonly due to MRSA, Aeromonas, or Vibrio vulnificus. And when there is, gas gangrene, that's typically due to Clostridia species. So Clostridium perfringens is, one of the common causes of gas gangrene. Now, when we look at all skin and soft tissue infections in general, most typically, collectively, most typical implications are due to Staph aureus and beta hemolytic strep. So you will see that the treatment is targeting these two organisms for the most part. Now, 80% of culture positive infections are from these two. And when it comes to Staph aureus, community acquired MRSA, is a big portion of it. And sadly, when you look at some of the data, you will see that when you compare inappropriate antimicrobials to appropriate antimicrobials, when it comes to Staphylococcus aureus, a good portion of treatments have been inappropriate, meaning no coverage, either due to resistance or due to inappropriate selection of antimicrobials. And that was, the ones with this are statistically significant. So less frequently implicated are, gram-negative organisms. So in general, we're not really worried about gram-negatives, anaerobes and yeast. Now, with clinical presentation of skin and soft tissue infections, essentially the hallmarks are erythema, swelling, warmth, induration, pain or tenderness at the site of infection. And for some of them that are purulent, draining, possibly coming from the wound. And they may be accompanied by signs and symptoms of a systemic illness. For example, there may be, depending on the severity, there may be fever and chills, diaphoresis, malaise, or elements of SIRS criteria. And we will use these to actually, when we select treatment, we will label some of these as mild, moderate, or severe, which I will discuss when I go over treatment.